Good afternoon. My name is Molly Knowles from the Integrated Care Resource Center, or ICRC. Thank you all for joining us today for this Working with Medicare webinar on coordination of Medicare and Medicaid behavioral health benefits. ICRC has developed this webinar along with other webinars in our Working with Medicare series to assist states in better understanding how Medicare and Medicaid coverage intersects for dually eligible individuals. Next slide, please. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's presentation. However, you can submit questions via Zoom at any point during the webinar by using the Q&A icon at the bottom of your screen. Closed captioning is available for this webinar. To use this feature, click on the Show Captions icon in the Zoom toolbar at the bottom of the screen. You are also able to edit the caption settings to adjust the text size by clicking on the upward arrow seen next to the icon. We will be recording today's webinar and posting the recording and slides on the ICRC website. And finally, as you exit the webinar, a page will pop up with a link to an evaluation survey. We would really appreciate any feedback you provide so we can continue to improve our technical assistance. Next slide, please. For those who have not attended our calls before, ICRC is an initiative of the Centers for Medicare and Medicaid Services Medicare-Medicaid Coordination Office, or MMCO. In partnership with CMS, ICRC staff helps states develop, implement, and oversee integrated care programs for people who are dually eligible for Medicare and Medicaid. To learn about future webinars or publications, or to receive updates about Medicare, Medicaid integration, and dually eligible populations, you can sign up for our email list by going to the homepage of the ICRC website and clicking on ICRC email updates. As I noted previously, today's webinar is part of ICRC's Working with Medicare webinar series, which is designed for all states interested in improving coordination of Medicare and Medicaid benefits for dually eligible populations. Webinars in the series include Medicare 101 and 201, today's webinar on coordination of Medicare and Medicaid behavioral health benefits, another on Medicare and Medicaid nursing facility benefits, as well as a webinar on state contracting with DSNPs. Recordings of all these webinars are available on the ICRC website. Next slide, please. Today's presentation will provide an overview of Medicare and Medicaid behavioral health benefits, including mental health and substance use disorder benefits for dually eligible individuals. We will first start off with an overview of the prevalence of behavioral health conditions among dually eligible individuals and Medicare and Medicaid expenditures for the care of these conditions. Then we'll talk about differences in Medicare and Medicaid coverage of behavioral health benefits, including the recent expansion of Medicare coverage of behavioral health services and providers. And finally, we will describe opportunities and strategies for states to improve coordination of behavioral health benefits in dual eligible special need plans, or DSNPs. We'll also save some time at the end for Q&A, so if you have a question during today's presentations, please feel free to enter it into the Q&A box, and we'll turn to those questions during the Q&A portion of the call. Next slide, please. Our presenters today include my three ICRC colleagues, Kat Fernandez, Matthew Fan, and Lita Momeni. In addition to moderating this call, I will also help facilitate the question and answer section. I will now turn to my colleague, Kat, to start us with a discussion of behavioral health conditions in dually eligible populations.
Thanks, Molly. I will be covering behavioral health conditions among dually eligible individuals and their effect on Medicare and Medicaid program expenditures. Next slide, please. Behavioral health conditions, including both mental health conditions and substance use disorders, are highly prevalent among dually eligible individuals. Over half of dually eligible individuals reported having a mental health condition. The chart on this slide shows the prevalence of 4 major mental health conditions among dually eligible individuals, separated by those under age 65 and those age 65 and older. Mental health conditions are consistently more common among the duly eligible population under age 65 than those ages 65 and older. For example, over a third of duly eligible individuals under age 65 have anxiety disorders and depression versus a quarter of duly eligible individuals age 65 and older with the same conditions. Those duly eligible individuals under age 65 also have much higher rates of bipolar disorders and schizophrenia and other psychotic disorders compared to duly eligible individuals age 65 and older. Most people under age 65 who become duly eligible for Medicare do so because they have a disability, which is sometimes related to a behavioral health condition. Therefore, we would expect to see higher rates of these conditions among duly eligible populations under age 65 compared to duly eligible population age 65 and older. In addition to mental health conditions, more than 1 in 10 duly eligible individuals have a substance use disorder. Next slide, please. Duly eligible individuals with mental health conditions often also have a comorbid chronic physical health condition. For example, the table on this slide shows that 75% of duly eligible individuals who had a mental health condition also had a heart condition. Similarly, 42% of duly eligible individuals with a mental health condition also had a musculoskeletal disorder. The prevalence of these comorbid conditions has important implications for care management. Please note that these data are taken from a CMS analysis conducted in 2014 with CMS Chronic Condition Warehouse data from 2008. This is the most recent publicly available information on physical and mental health comorbidities among duly eligible individuals. Next slide, please. Duly eligible individuals with behavioral health conditions have significantly higher cost of care than people with behavioral health conditions who are not duly eligible. The chart on this slide shows that the annual healthcare spending for duly eligible individuals under age 65 with a behavioral health condition is twice that of all other adults aged 18 to 64 who are not duly eligible. Please note that the data presented here are from the 2008 to 2011 Medical Expenditure Panel Survey, MEPS, which is the most recent data available comparing the prevalence of behavioral health conditions and healthcare expenditures among these two populations. Next slide, please. Medicare is the primary payer for care and services provided to duly eligible individuals. Overall, Medicare covers 60% of total healthcare spending for duly eligible individuals with a mental health condition. Medicaid covers 23% of healthcare spending. In the chart on this slide, Medicaid spending is for services not covered by Medicare, including residential services, case management, and partial hospital spending, as well as Medicaid services to wrap around Medicare to cover some inpatient and outpatient services and prescription drugs. Next slide, please. To summarize, duly eligible individuals experience high rates of mental health and/or substance use disorders. Duly eligible individuals under age 65 experience higher prevalence of mental health conditions compared to duly eligible individuals age 65 and older. And among those adults under age 65 who receive behavioral health services, healthcare spending is twice as high for duly eligible individuals compared to all other adults who were not duly eligible. Now I will pass it over to my colleague Matthew to present on Medicare and Medicaid coverage of behavioral health benefits.
Thanks, Kat. So now that we've talked about behavioral health needs in dually eligible populations, we'll now discuss how Medicare and Medicaid cover behavioral health benefits, including the recent expansion of Medicare coverage of community-based outpatient behavioral health services and provider types. Next slide, please. So we'll first start with Medicaid's coverage of mental health services. Many mental health services fall within mandatory Medicaid benefit categories that states must cover, such as psychiatrist services and rehabilitative services. States can also elect to cover additional mental health services through optional home and community-based Medicaid state plan services or waivers. On this slide, there's a table on the right which shows that the type of service and the number of states that cover the services vary. ranging from 45 states covering individual therapy down to about half of states covering psychiatric residential treatment. Another important point to note is that while all states cover prescription drugs for mental health conditions, for dually eligible individuals, Medicare will be the primary payer for most of those prescription drugs. Next slide, please. And in addition to mental health service coverage, Medicaid also covers a variety of substance use disorder services. Of note, Medicaid covers certain medications for medication-assisted treatment of alcohol use disorder and other substance use disorders. And in addition to coverage for medication-assisted therapy, many states also provide services through their Medicaid state plan, such as detoxification, psychotherapy, peer support, and crisis intervention. On this slide, the table on the right shows states' coverage of the continuum of SUD services, ranging from 44 states covering outpatient and intensive outpatient services to 31 states covering early intervention services. And before I move on to talk about Medicare's coverage of behavioral health services, I wanted to mention as well that states have another option for providing Medicaid coverage of behavioral health services, in addition to their Medicaid state plans and HCBS waivers. States can use Section 1115 demonstration waivers to improve the continuum of care for individuals with substance use disorder and those with serious mental health disabilities, also known as serious mental illness. So a key aspect to these demonstrations is that they allow states the flexibility to receive federal match for time-limited services provided to Medicaid enrollees who reside in institutions for mental diseases, or IMDs, which generally Medicaid is prohibited to cover for adults aged 22 to 64. To learn more about the IMD exclusion and the Section 1115 demonstrations, please refer to the appendix of this presentation. Next slide, please. So now let's talk about Medicare's coverage of behavioral health services. Medicare coverage of behavioral health services is split across Medicare Parts A, B, and D, with each part covering different types of services. When it comes to mental health and SUD service coverage, Medicare Part A covers inpatient mental health care and substance use disorder services in both general and psychiatric hospital settings. Medicare Part B covers outpatient mental health and SUD services provided by approved healthcare professionals. These services may include individual and group psychotherapy, psychiatric diagnostic interviews, medication management, and other services and therapies, which also includes screening, brief intervention, and referral to treatment, or SBIRT services. And Medicare Part D covers prescription drugs used to treat mental health and SUD conditions. Next slide, please. And in recent years, there have been substantial updates and expansions to Medicare coverage of behavioral health services. Firstly, in 2016, the Comprehensive Addiction and Recovery Act, or CARA, included provisions that give Medicare Part D and Medicare Advantage plans increased flexibilities to address opioid overutilization through drug management programs. Then in 2020, CMS began making bundled payments for opioid use disorder treatment services that were provided by opioid treatment programs, or OTPs, to people with Part B coverage. And most recently, as of January 1st, 2024, the OTP benefit now covers intensive outpatient program services, in addition to services already covered at the time of the program's inception. Next slide, please. And along that same vein of recent changes, as of January 1st, 2024, there has been a substantial expansion of Medicare coverage of behavioral health provider types as well. Starting this year, marriage and family therapists, or MFTs, and mental health counselors, or MHCs, are now both able to bill Medicare Part B for behavioral health services that they provide. In addition to this, addiction counselors and drug and alcohol counselors who meet requirements can now also enroll in Medicare as a mental health counselor and bill Part B for services too. And this expansion of provider types who can bill for Medicare Part B services also extends to rural health clinics and federally qualified health centers. So MFTs, MHCs, and other counselor types who qualify as an MHC within these settings can also bill Medicare Part B for services rendered. Additionally, in rural health clinics and federally qualified health centers, direct supervision changes have increased the ability of these new provider types to furnish services. Also, clinical social workers, MFTs, MHCs, and clinical psychologists can now all bill health behavior assessment and intervention codes. And in addition to those increased provider types who are now able to bill for Medicare Part B services, providers can now bill Medicare Part B for community support services rendered by community health workers, care navigators, and peer support specialists. Next slide, please. Along with an expansion of Medicare coverage for behavioral health provider types, there's also an expansion in the type of behavioral health services covered by Medicare as well. Medicare now covers intensive outpatient program services that are rendered at a hospital outpatient department, community mental health center, federally qualified health center, or rural health center. And as touched upon briefly earlier, intensive outpatient services can now also be furnished within opioid treatment programs for the treatment of an opioid use disorder, but only for individuals with an opioid use disorder, not for individuals with other substance use disorders that may be seen by OTPs. In addition to this, the Medicare payment amount for psychotherapy for crisis services has been increased to 150% of the fee schedule amount, only when furnished in certain settings other than the office setting, such as through mobile crisis teams or for services furnished in an individual's home. And in an effort to protect access to mental health services, telehealth will continue to be furnished to people in their homes. However, starting in 2024, telehealth will be paid at non-facility fee schedule rates. Next slide, please. And so before I conclude my slides, I want to leave you all with 3 key takeaways. First, through Medicaid, states are required to cover mental health services and substance use disorder services that fall within mandatory Medicaid benefit categories, and can elect to cover additional services through state plans or waivers. Secondly, Medicare's coverage of behavioral health services is split between Medicare Parts A, B, and D, with each part covering different types of mental health and SUD services. And third, the recent change in behavioral health coverage within Medicare expands both the types of providers and the types of services covered, allowing for improved access to behavioral health care for dually eligible individuals. And with that, I'll now turn it over to my colleague Lita for a discussion on state approaches and options for coordinating behavioral health benefits for dually eligible individuals.
Thank you, Matthew. In this section, we'll discuss the implications of Medicare and Medicaid behavioral health coverage differences, the challenges to physical and behavioral health integration, and strategies states can use to improve coordination of physical and behavioral health services for dually eligible individuals. Next slide, please. Let's first talk about some of the different layers of fragmentation that dually eligible individuals must navigate. In many cases, these individuals are navigating separate care delivery systems. First, as Matthew described, Medicare and Medicaid cover different behavioral health services, and they have different rules for processes like appealing a denial of coverage. Sometimes there's an added level of complexity in that there may be grant programs at the federal, state, or local level that are separate from Medicare and Medicaid that may cover behavioral health services as well. At another level, duly eligible individuals may need to navigate between different managed care entities, one covering their physical health care and another covering their behavioral health care. And even at the provider level, their physical and behavioral health services may be rendered by separate providers or provider organizations, and even their mental health and substance use disorder services might be separate. Next slide, please. Fragmentation of Medicare and Medicaid behavioral health coverage has implications for the ways in which care is coordinated and received. Fragmentation can lead to lack of coordination among providers, affecting, for example, the coordination of prescription drug utilization, potentially leading duly eligible individuals to be prescribed medications that could be harmful and unsafe when combined. Medicare and Medicaid each have their own coverage limitations. While Medicare has recently expanded its coverage of behavioral health services, there are still coverage limitations, and often what is covered by either Medicare or Medicaid is not coordinated. Medicare offers limited substance use disorder services. For example, it offers no coverage of community-based treatment facilities for individuals who need intermediate levels of substance use disorder care, and no coverage of residential treatment services. Overall, longer-term care and rehabilitative mental health services are limited, and while more step-down options are being offered, Medicare is still limited in its coverage of intermediate services. Additionally, federal Medicaid match continues to be prohibited for institutions for mental diseases, so this benefit varies by state. While there is a general trend toward managed care programs for behavioral health care, managed care purchasing models in many states still separate or carve out behavioral health services from other Medicaid-covered health services. Next slide, please. Further complicating coordination, Medicare limits the coverage of certain types of behavioral health providers, covering a more narrow range of behavioral health provider types than most Medicaid programs. And gaps in data can cause care coordination challenges, unnecessary duplicated services, and inefficiencies in claims processing for both Medicare and Medicaid programs. Next slide, please. I mentioned earlier that physical and behavioral health care services are often provided through separate delivery systems. Better integration of these systems can be challenging due to several factors. Data sharing challenges related to privacy concerns and system incompatibility can hinder mental health and substance use disorder providers' sharing of behavioral health data in collaboration with providers of physical health care, causing the delivery of physical and behavioral health to remain siloed. We will talk more about the challenges to information sharing in the next slide. Another challenge is having quality measures and payment incentives in place to promote provider accountability, both of which require some level of financial resources for states and managed care plans. There are also often administrative barriers to program monitoring and quality improvement, which are inherent in having separate Medicare and Medicaid payers and separate state-level mental health and substance use disorder systems. Different cultures of care delivery and separate and varying levels and types of professional training requirements for physical and behavioral health providers also pose challenges. These challenge areas are areas that states can focus on in developing initiatives that integrate physical and behavioral health services for duly eligible individuals. Next slide, please. Concerns about the interpretation of federal regulations and state-specific mental health codes around sharing substance use data can impede data sharing for substance use disorder treatment. The logistics around obtaining consent for the patient on what can and cannot be shared and with whom, the limited financial and staff resources to ensure timely information sharing, and limited adoption of electronic health records by mental health and substance use providers can all challenge information sharing. One helpful note is that a recent final rule modified the confidentiality of substance use disorder patient records regulations to simplify the patient consent process. Now a patient can provide a single consent for future use and disclosure of treatment, healthcare operations, and payment. The single consent also allows entities covered by the Health Insurance Portability and Accountability Act, also known as HIPAA, and business associates to redisclose records, aligning 42 CFR Part 2 with the HIPAA rules and the Health Information Technology for Economic and Clinical Health Act. Next slide, please. Before we discuss the approaches states can take to coordinate physical and behavioral health services and address some of the fragmentation and challenges, let's review the different types of dual-eligible special needs plans, also known as DSNPs, and their levels of Medicare and Medicaid integration. These Medicare Advantage plans only enroll individuals duly eligible for Medicare and Medicaid. All DSNPs have to at least coordinate duly eligible individuals' Medicaid benefits. DSNPs have to have 2 contracts, one with CMS and one with the state Medicaid agency, known as the state Medicaid agency contract, that has to address certain minimum federal requirements. States have the authority to determine which DSNPs they'll contract with and can include state-specific requirements in their contracts that go beyond the minimum requirements. On this slide, there are requirements for each DSNP type. Coordination-only DSNPs meet the minimum level of CMS requirements for DSNPs, but they do not typically cover Medicaid benefits. Coordination-only DSNPs must coordinate the delivery of Medicare and Medicaid services, and they must meet the admissions notification requirement. Highly integrated DSNPs provide coverage of at least some Medicaid benefits, and those Medicaid benefits must include long-term services and supports and/or behavioral health services. Starting in 2025, a HIDE SNP's capitated contract with the state Medicaid agency must cover the entire service area of the DSNP. This means that a HIDE SNP can only operate in areas of the state where a DSNP enrollee can also get their Medicaid benefits from the DSNP's parent company. At the highest level of integration, fully integrated DSNPs, or FIDE SNPs, provide coverage of both Medicare and Medicaid benefits under the same legal entity. This contract must cover Medicaid primary and acute care services and LTSS benefits, including at least 180 days of nursing facility coverage during the plan year, and they must coordinate Medicare and Medicaid benefits using aligned care management and specialty care network methods for high-risk enrollees. Starting in 2025, FIDE SNPs must also cover Medicare cost sharing, behavioral health services, home health services, and medical equipment, supplies, and appliances. All FIDE SNPs will also be required to operate with exclusively aligned enrollment beginning in January 2025. Like HIDE SNPs, a FIDE SNP's capitated contract with the state Medicaid agency must cover the entire service area of the DSNP. Importantly, while HIDE SNPs and FIDE SNPs may cover Medicaid behavioral health services, all DSNPs, even DSNPs that do not cover Medicaid behavioral health services, must still coordinate the delivery of their enrollees' Medicaid behavioral health benefits or services. Next slide, please. As Matthew described earlier, Medicaid behavioral health coverage variations are due to state differences in what is covered by a Medicaid program and how those services are delivered to full benefit duly eligible individuals. In states where behavioral health services are carved out of Medicaid managed care contracts, a DSNP can still meet the FIDE SNP or HIDE SNP designation if approved by CMS, and if the service carve-out primarily applies to a minority of the beneficiaries eligible to enroll in the DSNP who use behavioral health services, or the carve-out is a small part of the total scope of behavioral health services provided to the majority of beneficiaries eligible to enroll in the DSNP. So, for example, a state may allow most of its Medicaid behavioral health services to be covered by a DSNP. However, the state may still have a select few behavioral health services that remain carved out of DSNP coverage. This would not necessarily prohibit a DSNP from being classified as a HIDE SNP or FIDE SNP. Next slide, please. States with any type of DSNP, coordination-only DSNPs, HIDE SNPs, or FIDE SNPs, can use their state Medicaid agency contract to improve physical and behavioral health coordination for duly eligible individuals. For example, states can use their contracts to require behavioral health training requirements for individuals who directly provide services to duly eligible individuals, including DSNP care coordinators and providers. States can set interdisciplinary care team and health risk assessment requirements that incorporate the coordination and screening of behavioral health conditions. States can set standards for care coordination during crisis response and major care transitions. States can require DSNPs to include Medicaid behavioral health providers in provider directories and align behavioral health provider networks. And finally, states can require the use of data sharing platforms and procedures. For more information about these contracting strategies, you can review ICRC's new tip sheet on behavioral health coordination located at the link included on the slide. In the next few slides, we'll discuss these strategies further. Next slide, please. States may require DSNP care coordinators to have certain professional backgrounds and training in behavioral health, such as a degree in social work, psychology, or counseling. Peer support staff and other providers may also be required to undergo behavioral health training, such as learning effective communication strategies and connecting with those who have certain behavioral health needs. Such requirements can improve the screening and identification of enrollees who may have behavioral health service needs and link them to appropriate services. Massachusetts requires specialized training for staff supporting older adults with behavioral health needs. Training topics include cultural competence, anxiety, depression, trauma, substance use, and behavior change. In 2026, primary care providers will be required to complete training on the use of mental health and substance use disorder screening tools, instruments, and procedures. Next slide, please. All DSNPs are required to use interdisciplinary care teams to address enrollees' health and functional needs. To best address enrollees' behavioral health needs, states can require DSNPs to include certain types of providers in their ICTs using an integrated clinical model and/or the inclusion of behavioral health clinicians. States can require the inclusion of behavioral health clinicians who coordinate care across enrollees, Medicare and Medicaid benefits. This can streamline and ensure communication between providers and reduce duplication in care planning. In Tennessee, FIDE SNPs are required to operate an integrated clinical model and ICTs that include nurse practitioners, social workers, registered nurses and/or licensed practical nurses, and licensed behavioral health clinicians who coordinate care across enrollees, Medicare, and Medicaid benefits. Next slide, please. As a part of the DSNP model of care, DSNPs are also required to screen enrollees' physical, psychosocial, and functional needs through an annual health risk assessment. States can require DSNPs to include behavioral health-related questions in the HRA to recognize and treat behavioral health conditions to prevent complications, improve quality of life, and help reduce healthcare costs and ensure enrollees are connected to appropriate and timely care. To do this, Minnesota requires HIDE SNPs to include questions about behavioral health needs in their annual HRA. Next slide, please. To address a crisis or major care transition, states can require DSNPs to develop crisis response protocols to respond to urgent behavioral health needs and connect enrollees to providers during and after a crisis. Effective coordination while an enrollee is experiencing a crisis or a major care transition is key to responding to an enrollee's needs in real time and to sustaining their long-term behavioral health care coordination and improve health outcomes. DSNPs in Idaho are required to have nurse advice lines that can assist and triage callers who may be in crisis by staying on the line with planned enrollees while connecting them to a licensed behavioral health clinician, also known as warm transferring. In Oregon, DSNPs are required to work with Medicaid managed care plans and discharging facilities to develop a collaborative discharge plan to prevent avoidable hospitalizations or unnecessary readmissions. Next slide, please. Navigating and accessing behavioral health providers can be challenging and confusing for enrollees, especially when they must navigate separate Medicare and Medicaid providers. States can require DSNPs that align with Medicaid and managed care plans to develop and maintain a single provider directory that includes both Medicare and Medicaid behavioral health providers. This can simplify an enrollee's process to find a new provider. Further simplifying the search process for an enrollee, states can require DSNPs to have an aligned Medicare and Medicaid provider network. Washington requires provider network alignments by requiring its DSNPs to have 80% of the DSNPs affiliated Medicaid managed care plans network providers in the DSNPs Medicare network to support the coordination of Medicare and Medicaid benefits. This requirement also aids in continuity of care for people who transition from having only Medicaid benefits and only Medicaid managed care plan coverage to having both Medicare and Medicaid. Next slide, please. As we discussed earlier, data sharing is an important piece to integrating physical and behavioral health care. States have opportunities to improve monitoring and sharing of physical and behavioral health claims and provider information across Medicare and Medicaid by requiring DSNPs to use collaborative data sharing practices and platforms. States can also require DSNPs to use data sharing platforms and procedures to document behavioral health referrals and prescription medication and make timely data entries. In Massachusetts, DSNPs are required to document and monitor behavioral health referrals in the enrollee's centralized enrollee record and make timely data entries about the behavioral health assessment, determined diagnosis, prescribed medications, and any individualized plan of care to promote provider collaboration. Next slide, please. I want to close this part of the presentation with the following key takeaways. Duly eligible individuals often navigate separate systems for physical and behavioral health services with varying covered services and program rules affecting mental health and substance use disorder services. Differences in Medicare and Medicaid behavioral health coverage can challenge the coordination of prescription drug utilization, result in unaligned services and covered providers, and cause administrative and operational challenges due to data gaps. States vary in the behavioral health coverage for duly eligible individuals, and the degree of behavioral health service carve-out affects HIDE-SNP and FIDE-SNP designation. And lastly, states can use DSNP contracting strategies to improve physical and behavioral health coordination for duly eligible individuals. Now I'll turn it over to Molly.
Thanks so much. And thank you, Kat, Matthew, and Lita. That is such great information for our audience. I would now like to invite any questions for our panelists. Next slide, please. Thanks. So as a reminder, feel free to share your questions through the Q&A feature, which is located at the bottom of your screen. So we've had a few questions come in through that Q&A icon. The first question, it looks like for Kat. So the question says, you mentioned, Kat, that 1 in 10 duly eligible individuals have a substance use disorder. Could you clarify if that is for duly eligible individuals under age 65 or over age 65?
Thanks so much for the clarifying question. The prevalence of substance use disorder among duly eligible individuals we mentioned is for all duly eligible individuals. We do not have recent data that stratify the prevalence of substance use disorders by age for duly eligible individuals. However, we do know that mental health conditions are more prevalent among duly eligible individuals under 65.
Great, thank you so much for clarifying. We have, it looks like another question that has come in. Again, I think this will be for Matthew. Matthew, you had mentioned earlier that Medicare will continue to cover telehealth for people in their homes. And so does this cover all behavioral health services?
Yeah, thanks, Molly. So that's a really great question. So the majority of behavioral health services that can be furnished in a virtual setting will be covered under this continued protection of telehealth-related behavioral health services. But a notable exception is for programs like partial hospitalization programs and intensive outpatient programs. So under the 2024 Hospital Outpatient Prospective Payment System Final Rule, Medicare cannot pay for PHP or IOP services furnished to beneficiaries in a home or residential setting. So those services would still need to be rendered in a hospital outpatient department, community mental health center, federally qualified health center, or a rural health center, or an OTP for those who have opioid use disorder. But people with Medicare who are in PHP or IOP programs can still receive other mental or behavioral health services via telehealth that don't pertain to their PHP or their IOP. I hope that helps to answer your question.
Yes, thank you very much, Matthew. Really great questions. We have another question that's come in around FIDE and HIDE SNP designation. So Lita, could you please explain again how the coverage of behavioral health services affect FIDE or HIDE SNP designation?
Sure, thanks, Molly. Yes, so states vary in how they cover behavioral health services. So certain state Medicaid programs may require that all or certain Medicaid behavioral health services be covered under a capitated rate through a Medicaid managed care contract. When a state excludes certain behavioral health services from what is covered under the Medicaid managed care contract, these behavioral health services are carved out of the managed care capitation contract and are paid through fee-for-service Medicaid or another entity such as a prepaid inpatient health plan. So a state may require DSNPs to provide behavioral health services under a capitated contract. Starting in 2025, HIDE SNPs must cover behavioral health services, although HIDE SNPs must cover behavioral health or long-term services and supports. If a state has some small behavioral health carve-outs, MMCO will determine if the DSNP still meets HIDE or FIDE SNP designation.
Okay, great. Thank you so much. Yes, again, please feel free to submit any questions through the Q&A icon at the bottom of your screen. And we have another question that's come in. This is looks like from Matthew. So on one of your previous slides, you mentioned that there were direct supervision changes in RHC and FQHC settings. Could you expand on what that means?
Yeah, of course. So traditionally, auxiliary personnel like therapists or counselors who work within these RHCs and FQHCs, they've had to furnish behavioral health services under the direct supervision of a physician or a non-physician practitioner to be able to bill Medicare. And while that physician or practitioner doesn't have to physically be in the same room while those services are being rendered, they have to be immediately available to provide assistance and direction throughout the time the service is being furnished. And so this new final rule shifts this now to become general supervision. So services still need to be furnished under the billing physician or practitioner's overall direction, but the physician or practitioner can now be on call and doesn't have to physically be present at that FQHC or RHC, such as being available by telehealth if they need to be communicated with. And so this update will enable both FQHCs and RHCs to bill Medicare more regularly for behavioral health services and allow for services to be furnished more efficiently for any dually eligible individuals who reside in settings with limited provider access.
Great. Thank you so much, Matthew. Let's see here. We have another clarifying question. This one would be for Lita. My state only has coordination-only DSNPs. Can you clarify whether the approaches you reviewed can only be used by co-DSNPs? I am particularly interested in the HRA and ICT strategies. How would I go about including such requirements?
Sure, thanks, Molly. That's a great question. So yes, most of these approaches can be used by states with coordination-only DSNPs. All DSNPs must meet essential care coordination requirements, including but not limited to conducting initial and annual health risk assessments, developing and implementing comprehensive individualized care plans, and using interdisciplinary care teams for care management. States can use their DSNP contract authority to expand on these minimum care coordination requirements to improve behavioral health and physical health coordination. I hope that answers the question.
Yes, thank you very much. And we'll just check for the Q&A. It looks like one additional question has come in. Let's see here. So is there more criteria CMS can provide regarding the extent of carve-outs and eligibility for FIDE and HIDE SNPs? So this question is specific to Indiana. So Indiana has, the questioner mentions that Indiana has carve-outs, but MMCO has decided to be FIDE eligible based on utilization. So would really appreciate knowing more about, the question would listener would appreciate more information about standardized and clear criteria. I think actually we'll turn to some of our other ICRC colleagues we have on the line. And so Erin Weir-Lakmani.
Hey, everybody, and thank you for that question. I know that the criteria for the FIDE SNP and HIDE SNP with the allowance of carve-outs is quite nuanced, and allowing for carve-outs in certain circumstances does make this a more complex thing to understand. And I want to be clear that I certainly cannot speak on behalf of CMS with regard to this. So we will definitely take this question and this comment back to our colleagues at CMS for thought and consideration as well. And I'm sure that they will appreciate it. But I can share, from my perspective, having worked in the space of integrated care with a number of states and in partnership with CMS for several years now. One of the reasons I suspect that it is very, very difficult for CMS to release very clear-cut criteria in this regard is because if they were to release very clear-cut criteria, it would probably result in fewer states and plans being able to meet these FIDE and HIDE SNP qualifications. It really wouldn't actually allow for consideration of unique and particular state context. And so for example, CMS could say no carve-outs allowed, right? 0 carve-outs. And if they did that, then that would, it sounds like from the description, that would mean that Indiana couldn't have FIDEs, and it would mean a lot of other states couldn't have FIDE SNPs or HIDE SNPs. And so I think when CMS established these FIDE SNP and HIDE SNP criteria, they were very thoughtful about the fact that when you get into the nitty-gritty details of coverage of particular benefits, there can be long lists of different kinds of benefits that qualify as either behavioral health or LTSS. And so it can get really complicated if you try to say something like you can have 3 carve-outs, right? That doesn't really make a lot of sense on the ground. So they went with this concept of the carve-outs needing to have the minimal impact that Lita described. And in order to make that determination, that does ultimately mean that CMS is going to have to then partner with states to figure out the extent of the potential impact of particular benefit carve-outs. And it does make it this more nuanced, case-specific sort of consideration versus having a really strict rule that then means it actually leaves a lot of states and a lot of DSNPs out. So I want to be clear again that this is just my own perspective from working in this field for a while. It's not representative of CMS or of their thoughts or comments. And so we'll definitely still take the comment and question back to them as well. But thank you. It is a really good question.
Yes, thank you very much. And thank you, Erin. We've had one last question, at least so far, come in. So I think this would be for Matthew. My state also covers intensive outpatient program or I guess the IOP services for people with Medicaid. And so what does the Medicare expansion to IOP services mean for dually eligible individuals in my state trying to access these services?
Yeah, thanks, Molly. That's a really important question, and thanks to whoever asked it. The expansion of Medicare coverage of IOP services within a state like yours, where Medicaid also covers the services, means that Medicare will now become that primary payer for IOP services for dually eligible individuals.
Great. Thank you so much for clarifying, Matthew. I'll just check one more to see if anyone else has any questions. Again, please feel free to use the Q&A icon at the bottom of your screen to submit any questions. So thank you everyone for participating in today's webinar, and thank you to all our presenters. If you would like to revisit today's conversation and the slides, a recording of the call and the presentation will be uploaded to the ICRC website. I urge you all to visit the website where you can find links to past calls, webinars, and briefs, and also submit technical assistant requests. We hope that this has been valuable for all of you today. And again, if you are logged into Zoom, please complete the survey that will appear at the end of the webinar. We're really looking forward to reviewing your feedback and making any changes to future webinars. The survey will also be sent out through email with the recording and the slides after the webinar. I also wanted to quickly share with you the resource slides that we've included as an appendix that relate to today's presentation. Thanks again to our presenters, our partners at CMS, and to all of you for joining us today.